This is a beautiful evening, and we're really excited to welcome you here by the still waters. My name is Dr. Ryan Christensen. I'm the founder, owner, and chief wellness officer of Still Waters Osteopathy, Lake Orion. We are an integrative boutique bespoke osteopathic healing experience here in Lake Orion, Michigan, and I'm really excited to welcome you all to something I'm really passionate about, and that's osteopathic manipulative medicine. Oftentimes, we use a couple of different terms for osteopathy, and I'm going to talk to you at a lot of different levels today. But what I'm really excited about is that everyone can kind of bring their open hearts and see how their own body is feeling today. And can everybody hear me okay? I think the sound looks pretty good. So, if that, we're going to get started. So, osteopathic manipulative medicine came to me as I always wanted to be a doctor. And one of the things that I was privileged is to get a chance as a medical student and a resident to work with Dr. Viola Fryman. And this talk is dedicated to my mentor, Dr. Viola Fryman. And this is a picture of me in training with her at her office in San Diego. So I'm the 100% owner of my practice, Stillwater's Osteopathy, Lake Orion. We have a wonderful team with Nurse Mary, Lori, our paramedic, Wyatt, an EMT, and some really beautiful folks who have come through. I'm also a clinical assistant professor at Michigan State University College of Osteopathic Medicine, and I'll tell you a little bit more of my story, but I had a wonderful journey after coming to Michigan to train in residency. I decided after working with Dr. Fryman that I would join an only osteopathic residency training program, and I matched to Pontiac Osteopathic Hospital in 2012 for a combined emergency medicine and family medicine residency. And it was really exciting for me to get a chance to see all of the options that were available in medicine. But I was always struck with the hands-on stuff. And from the first days of medical school, I was like, what is this different thing that the DO doctors are doing, right? And I saw that the patients actually had a different response. And I got really interested seeing that when we were learning in medical school how the body would work together with the person treating, and that magic seemed to happen. So I was privileged then to get to learn a little bit from Dr. Fryman in my basic cranial course and be mentored by some wonderful folks, Dr. Heath. And what happened is I started to understand what this man understood, and his name is Dr. Andrew Taylor Still. Dr. Still was the founder of osteopathy, and he founded this in 1874. And he said one of his famous quotes, "To find health should be the object of the physician. Anyone can find disease." And one of these things, it was really a big difference in the time. And think about this. This is bloodletting. This is other things that Dr. Still said he didn't discover osteopathy. He really revealed it. And he was one who wanted to bring to the house of medicine this idea that structure and function are related and that the body is always working towards self-healing, self-regulation. And we call these the osteopathic tenets. So today we're going to talk about seeing what we can name as the 4 tenets that describe osteopathic principles and practice. And one thing about osteopathy is it's very much a philosophy of treatment. So one of the concerns I have is a lot of DO schools are moving to a more curriculum based on similar to other healthcare providers. And while I really appreciate that, we want to make sure we understand what are these tenets and what did Dr. Still mean when he talks about osteopathy. I'd like you to determine and define what somatic dysfunction is. These are known as osteopathic lesions, and this is what we're feeling for and the characteristics of this. And we can understand who can safely and successfully perform osteopathic manipulative treatment, and I may abbreviate that as OMT. And we're going to talk about the indications, some patients, and we'll definitely have time for questions. So buckle up, it's going to be a really exciting evening. So this is our incomplete history of OPP, or osteopathic principles and practice. And let me summarize this in a nutshell, that because of the closeness and the proximity between the vertebrae and the autonomic nervous system, this neuromuscular system, the symbol from sending from the brain through the spinal cord to the nerves, is vital to maintaining balance of the body and homeostasis. So one of the things is you can think of this like being on a teeter-totter, right? Like if it goes too far one way or too far this way, we have to be in balance. And there's always going to be stressors coming at our system that as an animal, as an organism in the earth, we have to be able to adapt. And so sometimes people talk about this concept of stress. And usually it's kind of like rhythm. There's a stress and a release, right? A stress and a release. And when we think about the body, you're going to notice some of these same cycles that come through. And this balance is something that I want you to kind of start thinking about and maybe noticing, like, check your pulse. Take a moment, just notice where your body is today. My little shoulders are kind of high. I'm sitting a little forward. I've been really excited about this all day. And then just see actually how you feel. Yeah, that's right. Good. Just noticing how you settle. And like there's some tension in my left hip today. That's something that you notice once in a while. And so what do you do when you notice this? Does it give you fear or does it take you back to a place where you can say, hey, something has shifted in my body and I need to learn to listen to it? That's one of the secrets of osteopathy too, is learning to listen to what your body is saying. So if you had one slide to take home, this is it. What is osteopathy? Osteopathy is a system of healthcare that uses a hand-on approach to treat the causes of pain and dysfunction. It's a form of natural medicine that focuses on restoring and maintaining physical well-being of your whole body. You've heard before that 80% of the body is water, correct? What happens in all the empty space that's not nerves, arteries, veins, lymphatics, muscle? What is in the rest of that space? Actually, turns out we found out that there's a whole nother organ system called the fascia, Fascia, fascia. And fascia is that connective tissue that is such a big part of how the whole system is connected together. And it's one thing that forms so much of your body that most of your doctors have probably never talked to you about or shared that there's something that you can do to influence it. We believe as osteopaths and osteopathic physicians that for the body to remain in good health, all parts must function together properly designed and intended. If one part of your body is restricted, the remainder of the body is going to compensate. And that is adjust around that dysfunction. And so you'll see a lot of people in like a chiropractic model focusing on spinal alignment, right? Is it straight? Is everything stacked up right? That is a key component. But what we talk about often is the concept of a key lesion, like a single area that is causing the primary dysfunction, and then how the body adapts around the rest of it. So the remainder of the body, remember, it's one single giant organism, maybe more like a colony of 5 trillion cells. And we assign them into different systems, right, to kind of keep it organized. But the body itself is more of a continuum than any kind of compartmentalized system. So what we know is that when we're influencing the soft tissues, we're also influencing the ligaments and the bones. And when we talk about compensation and restriction, that compensation can lead to stiffness, inflammation, which is the red, hot, swollen, ropey. And we hear a lot of talk about inflammatory foods, but inflammation usually leads to discomfort and pain, and even at risk for infection because of lower immunity. Another thing we believe is that our bodies have this amazing ability and capacity for self-healing. Did you think about the last time you cut yourself? Did you have to consciously send all of the blood products to your finger? No, you were busy crying and running around and cleaning up the mess. Your body's inherent wisdom sent the exact right signals to that place. And the inflammatory mediators are designed to protect us. And that's one of the reasons that fever in kids, like we're not going to cook their brains. For most people, there's a set point of this. And we know that that immune system is activated with temperature. So when the body is balanced like a well-tuned engine, it will perform with minimum wear and tear, leaving more energy for your living. And our osteopathic hands-on treatments will help restore this body's natural ability to heal itself. So we as osteopaths, and I use the term, we're going to talk about this in a second, and osteopathic physicians recognize the patient, the person who's coming, you all out there, you are already whole. You are already integrated. And when those components are in balance, you are going to feel so amazing. You're going to feel completely like safe in your body. You're going to be able to respond to stress and threats. You'll be able to sleep easily, eat without dysfunction, and allow the best life to happen. So we're really excited to see how do we do this. So there's four tenets. And the four tenets of osteopathic medicine are that the body is a unit of structure and function, and that structure and function are reciprocally interrelated. Now, that's an interesting one because what we've usually thought is that function is a outcome of the structure, right? Like a wheel rolls because it's round. Well, or is it round because it rolls? The osteopathic approach is one that thinks of structure is actually found by the function of the embryologic development. And this is a really important point that a lot of people don't get about the tenets. These were formed actually in the 1950s by the American Osteopathic Association, but they were trying to summarize how Dr. Still understood this. And in a time of bloodletting and arsenic as the pills of choice, there were very few options. So the story goes that Dr. Still actually had a headache one day. He hung a rope around a tree and laid back and took a nap. And he woke up and he was like, my neck is better. And I wonder if the structure and function could have caused this. And it came to him, he says, like a lightning bolt. That he didn't actually discover osteopathy, he just was the one who wrote it down. And when we talk about a treatment, we have to integrate all these three things and in the context of the patient and the person's life. Because without understanding the context of what people are going through, it's very difficult to get to a good diagnosis and a good outcome for people. And these are the osteopathic tenets, which are like our hallmarks. So let's talk about how did osteopathy come to be? And it was founded, he said, flung the banner of osteopathy 150 years ago, actually last year. June 22nd, 1874, by Andrew Taylor Still. He was a frontier MD. His father was a Methodist minister. And his intent at the time as an MD was not to create a separate profession, but to improve our present system of medicine by giving it a more rational and scientific basis. And what did he mean, rational and scientific? Well, medicine in the 19th century, as I said briefly before, was not the same as we have now. There was epidemics of this late 1800s, cholera, smallpox, tuberculosis. He was very disenfranchised because this was the pre-antibiotic era and the Civil War. And you remember hearing about all the amputations and all the infections. I mean, there were people at this time like not necessarily washing their hands before surgery because germ theory was still like not completely well accepted all over. And that's what we found is that on this American frontier, in actually Missouri, of all places, this man, Dr. Andrew Taylor Still, he really lost faith in the medical profession. And he was a frontier doctor, as I said, but the story is that he actually had some interactions with Cherokee Native elders. And that one day he dreamed and just got all of this information and he was known as a lightning bone setter. And Still's other story that's just very interesting is he had 6 children. 4 of them actually died from spinal meningitis. And he prayed and he said, like, how could all these terrible things happen and God not give us the ability to heal ourselves? And remember, everything was kind of in a Christian ethic at that time. So I think we have to look at Still's faith as kind of an expression. He was also a spiritualist. And so he was very known to light candles and communicate. And the type of philosophy that he talked about is an oral tradition. It's a lineage of hands-on treatment passed through the different generations. And many of us have osteopathic pedigrees working from some of the folks through. And it's really beautiful because in our community, there's been so much expansion of the types of treatments since Dr. Still's time. Dr. Sutherland got into the cranial concept, and we'll talk about that. Our new understandings of lymphatics from Dr. Core. The autonomic variables studied by Dr. Louisa Burns in the 1940s. And there were some really cool things too, like Dr. Still's school in 1892 was half women. There was, I believe, 4 women and 6 men in his first class at the American School of Osteopathy in Kirksville, Missouri. And that was nearly 50 years before a woman was admitted, regularly admitted to MD medical school. Dr. Stills believed that the body was closely related, function was closely related to its structure, and that problems in one organ would affect other parts of the body. And this was really revolutionary for the time and kind of still is, especially when doctors are saying that the body is separate, isolated parts as we tend to see it in our common medical system. Still maintained the physician could best promote health by ensuring that the musculoskeletal system was in alignment, and that would minimize his obstructions to blood and lymphatic flow. And this is known as Dr. Still's rule of the artery. He's known to say the rule of the artery is supreme. And let's think about that for a second. The arteries bring oxygenated blood, right? And that's what is the water, the nutrients for the body's body systems and the physiologic function. So the first osteopathic schools were started in 1892. The American School of Osteopathy opened in Kirksville, Missouri, which is now Kirksville College of Osteopathic Medicine, which still exists. And I actually graduated from the sister school, ATSU Soma, in Mesa, Arizona. And in 1897, the American Academy of Osteopathy was formed, which is now the American Osteopathic Association. It's the main governing body of our osteopathic profession. And this was Still's house, actually, and it's still in Kirksville, Missouri, in the museum there. But some pictures from the early days of osteopathy. 1892, the first school opened. And you'll remember hearing about the Flexner report. If you're familiar with medical education, there was a big standardization that occurred around 1910. And actually, there was a couple of DO schools that made that transition. This is when the homeopathic schools were closed. A lot of the other types of healing, there was magnetism, there was all kinds of healing schools. And so Flexner was actually hired by Carnegie's to scientific medicine and to help it actually there was a lot of oil stuff starting to happen. So this was really when we saw the birth of the pharmaceutical industry. The American Osteopathic Association then mirrored a lot of these requirements in osteopathic schools. And it was Kirksville and Des Moines University, I believe, that were the first two credentialed schools, or maybe Philadelphia. But they moved and mirrored medical education for MD allopathic physicians. And I'll use that term a couple of times. And if it's confusing, allopathic is MD, DO is osteopathic. And so we'll talk about the kind of two schools of American medicine. So in 1929, pharmacology and surgery were required osteopathic curricula. And this was a time that Dr. Still was talking. He always taught surgery in his courses because when an organ got too diseased, that was appropriate to remove it. And he saw how amputation saved lives during the Civil War. So he was never really against the establishment. He just wanted to find a better way to do things. And in 1947, the first osteopathic residencies were approved for osteopathic postgraduate training. And we saw that because a lot of the MDs were actually sent off to World War II, and the DOs were allowed to remain because they were not quite considered real doctors by the establishment. And after World War II, when people got a taste of osteopathic medicine, there was a real growth that happened. In 1957, it was the U.S. Department of Health recognized AOA's accrediting body, and it was until 1973 that DOs were licensed in all 50 states and the District of Columbia. In 2014, when I was in residency, their single accreditation system happened, merging osteopathic residency training and postgraduate education together with our MD colleagues. And so now there's residencies that have osteopathic distinction, and I was privileged to be an osteopathic residency director. And when we talk about now, the osteopathic profession has grown dramatically to the point that 40% of the new DOs coming out in 2025 are under the age of 40. So we have a really beautiful opportunity to help people understand the power of healing. And for really the first time in my experience, most of the learners coming to osteopathic schools are choosing that instead of MD because of this philosophy, because of this idea of care, and it's really attracting a lot of really, really talented, qualified, amazing humans. So in 2020, the programs were fully accredited together. And that also gave a beautiful bridge because it gave us some opportunities to begin teaching OMT a little more formally to our MD colleagues. And now there's actually MDs that will come take the osteopathic trainings and practice very osteopathically. So this was 2023 data, but there's 148,829 osteopathic physicians in the US. There's 38,000 osteopathic medical students, and you can see some of this growth. And the 2023 data, it's only climbed with more schools opening, more residency programs, and people are preferring to speak with DOs because of their philosophy. One of the biggest complaints I hear is that there's not enough doctors doing this hands-on type of medicine. Or I called my DO and he doesn't do what you do. Why? Well, a lot of it ties into reimbursements, and part of the reason we have to create a lot of cash practices is because insurances don't yet understand the value of this and how much money it can save people and how much quality of life it can improve. And the hard thing is the data is not quite the same as pharmaceutical data, that you can't really randomize touching people. So we've tried. We've done sham touch. We've done, again, just gentle hands-on, and there's a response. But a lot of the statistics aren't well powered in that yet because I think our measurements are not quite where they need to be. So let's talk a little bit about the differences between some of the common manipulation physicians that you'll see. One of the biggest questions I'm asked is, hey, Dr. Ryan, what's the difference between a DO, an osteopathic physician, a DC, a chiropractic physician or a chiropractor, and a PT or a physio or a physical therapist? So let's break it down now. Osteopathic physicians have 4 years of osteopathic medical school. We are required, similar to an MD allopathic, to do 3+ years of residency required to become board certified. We are licensed in each state to practice medicine, surgery, and osteopathic manipulation. We do use thrusting and other hands-on techniques, but it's usually manual only. And coding and billing is for manipulation in addition to our physician code for injury or pain. So when you get a super bill from us, it'll always have your doctor visit and it'll always have your manipulation code there. Because part of what we're doing is we're assessing the body each time, finding dysfunction. If it's present, there's an indication to treat it. And then we're hoping that as you learn and your body learns, that it improves and goes away. Chiropractic physicians do 4 years of chiropractic school. They have an optional residency, and they're licensed to practice hands-on manipulation, specifically focused on the spine is their tradition. They historically will use a lot of cracking and popping and thrusting techniques, sometimes the little activators and the guns. And again, chiropractic is a really great, if like firm joint mobilization is your thing, there are some very talented chiropractors. But what's happening in chiropractic is a lot of merging like what's happening in osteopathy, as that techniques are getting gentler and slower. And they're seeming to do a lot of like, you'll hear about energy chiropractic and gentle things. And many of the things that people are describing as new techniques in the physical therapy and chiropractic world are repurposing osteopathic techniques that have been around for about 100 to 150 years. There was a lot of residencies and research, in the 1920s in the Still Sanatorium, including they were using hydrotherapy and light therapy for mental illness and bipolar disorder, like prior to the times when we had really good ways of treating this. So it's really fascinating to see, too, how much the profession has grown and continues to grow. And let's talk about physical therapists. Physical therapists are now a doctoral level clinician in most places too. And that's been a really great boon for medical practice. But a lot of people are now happening to get sent to physical therapy, kind of like the dumping ground. Like, oh, you have vertigo, you have dizziness, you have all this pain, you need a joint replacement. And they send you to PT and they say, do this for 6 weeks. Many of them are very talented as well. They also have optional residencies and postgraduate training, but physical therapy is licensed to exercise, neuromuscularly re-educate, and do hands-on manipulation. The physical therapists traditionally use like non-thrusting techniques, often with more modalities, and the physical therapists have a lot of cool modalities. But the billing and coding for them is for their modalities only. Most of them, unless they're a cash practice, require a prescription from your physician that's ordering this to treat. And sometimes they can be a little narrow-minded in that we're prescribing physical therapy for a knee joint, for example. And, in the joint, you have some space around there, above and below, in the tibia and fibula, and up into the femur. And sometimes they, as we all can, focus in a little narrowly instead of looking at how the whole body is working together. So This is another class of another quick one, and I'm not going to spend quite as much time here, but I want to compare the MD-DO differences here with the DC. These are probably the most common physicians most people will see, and that's either chiropractic, allopathic, or osteopathic. So MDs and DOs have a 4-year degree that is required in undergraduate, and chiropractors have a 90-hour college credit that's typically required, but again, a lot of professions are advancing. There's a 4-year degree for everyone as a graduate school degree. And postgrad training, as you notice, the DOs and MDs, as I talked about that merger, is the same. We do a 1-year internship, 2 to 8 years of residency, depending on the specialty. And I did a dual residency in family medicine and OMT and emergency medicine at McLaren, Oakland, and Pontiac. The chiropractors are not required to have postgraduate training. Many of them do and extra pieces, but no formal requirement for that. Licensure and scope of practice is determined by each state of practice, but MDs and DOs are the only two types of doctors that are fully licensed to practice the complete spectrum of medical and surgical specialties in all 50 states. And we can both prescribe medications, especially as US trained DOs, and chiropractors do not have that privilege. And then manual medicine training, when the MDs are getting a bit of a break in our medical school, the DO students are actually in our labs learning hands-on manipulation. And so we have an extra 500 hours of training in hands-on modality based on undergraduate curriculum. The other thing you'll hear me use is the term osteopath versus osteopathic physician. DOs that are trained in the United States are known as osteopathic physicians, and we have the full licensure as a physician. And there's some confusion because even in Canada, in the UK, the DO degree is a master's level that as they're similarly to chiropractors in the rest of the world. They have many great hands-on modality. In the UK, they're allowed to diagnose as well, but they have a little bit different scope of practice. So one of the questions you'd like to ask your body workers or your physicians or your DOs is, hey, where did you train? Are you a US trained DO or are you an osteopath? And both work really well together, and you can get a lot of benefits from both. The other thing is we're finding a lot more MDs that are learning and coming to our courses and doing a ton of osteopathic treatment. And also manual therapists, certified lymphedema therapists, craniosacral therapists, a lot of people have the ability to touch. And it's really cool that people can now start to know who's on the other side of that. So who can perform OMT? Any AOA, so this is from the osteopathic some of the Medicare requirements as well. It's any osteopathic medical school graduate completing an AOA or ACGME accredited residency. They may perform OMT within their scope of practice and specialty. Or any allopathic, that's an MD physician who's completed osteopathic accredited CME, may perform OMT within their scope of practice, specialty, and CME certification. And then if anybody has had a 3-year residency in osteopathic manipulation, we do have board certification in osteopathic neuromuscular medicine, and there are separate residencies for that currently. So let's get into a little bit more how treatment works. And changes in the musculoskeletal system can affect the visceral organs. And then visceral organs can actually manifest as tissue changes in musculoskeletal texture. So we think about how the brain sends signals down the spinal cord. It comes out the cord and it goes to the organ, right? There's also a feedback loop. And the ribs going around are innervated with the same nerves that the organs are. Who knew? So a lot of this came out of research in the 1940s when they figured out that if they twisted a little spine and they could change and put the animal into heart failure. They actually did this on rabbits, Dr. Burns' research. And they could fix the vertebrae, and within a couple hours, the bunny would be out of heart failure. They figured out that the levels from T2 through 4 affected the heart. And down to even T6 in some, but around that T4 area. And that matches exactly with these levels that are called viscerosomatic. So somato means the body, and visceral means the organs. So a somatorovisceral stimulation can lead to a viscerosomatic reflex, or vice versa. And so sometimes what we're feeling for, we can run our hands down your spine and be like, hey, this feels really strange. Is your organ okay? And people look at me like I'm crazy when I can use my hands to diagnose, but this is how we do it. So these musculoskeletal changes that we palpate as doctors and as osteopaths is known as somatic or body dysfunction. And there's actually codes that we put in, the M99 codes, that is the diagnosis codes for somatic dysfunction. Unfortunately, insurance says to bill them, but they don't pay for it. So that's one of the reasons that a lot of your doctors aren't doing as much OMT, is because these codes aren't seen as important as some. And somatic dysfunction is palpable, so it's touchable, and we can feel it on our structural exams, and we can treat it with manual medicine techniques, including osteopathic manipulation. So let's get a little bit more into what is this somatic dysfunction. You know, when I had you check through your body earlier, check it again. Do you notice how that pain is not in the same spot, or the tension is not quite in the same spot, right? Maybe you've been sitting forward or a little more tense. So notice again, I'm feeling it now, my mid-back on the right. That's really interesting. So impaired or altered function of any part of the soma, that is skeletal in the bones, myofascial, myo means muscle, and fascial means that connective tissue, and any related vascular, blood flow, lymphatic, and neural elements. And we're going to talk more about lymph too. This is diagnosed by touch, palpation, and what we're feeling for is freedom of motion versus restriction in range of motion. These are known as TART. And you'll hear the DOs, we love to talk about TART, us bone wizards. And tenderness is the big one. Tenderness and pain is something that most people have when they come to the doctor, even if they don't want to admit it. Because usually nobody comes and sees us because they're having the best day ever. There's a few of you, but most people wait a while to come in and get seen. When I do a structural exam, I have people stand up and I'll look at them from both sides, and you'll see me putting my hands at different places, and I'm feeling for height. So I'll note the left shoulder is high, the right hip is high, and any type of asymmetry. Remember, the midline of the body is key for embryological development, and if that line is not the same, it's not going to have the right tension, and your body's going to have an imbalance. Restricted range of motion is the other thing. So knowing how far a joint should move, and when it even gets a little bit restricted, it puts a lot of pressure on the organism. Think about the last time you've hurt a toe or a shoulder or a finger and you tried to do something with it. Like, it's amazing how much a little bit of restricted range of motion can change your whole day, your whole week. And then lastly, and most important for us as DOs, is the tissue texture changes. Somatic dysfunction has a certain feeling, and one of the things I love to teach new folks learning to palpate is I ask the question, what does health feel like? And to me, health feels like freshly proofed bread dough. The one that you kind of punch back into the bowl and then roll it up, because it's elastic and it's warm and it's soft. It has a vitality and an energy to it. It's almost light, right? Like, yeah, the baguettes, Mael knows. It's perfect. But when we talk about that, fresh babies feel that way too, for those of you who haven't held a baby in a while. But this tissue texture is soft, it's buttery, and that's what normal tissue should feel like. You shouldn't run your fingers through it and feel ropey, chronic, lumpy, crunchy. Ugh. And that's oftentimes where we start with our somatic dysfunction. So there are barriers that we talk about in osteopathic medicine, because one of the things that I really want to cover is how do we know what we're doing is safe? Many people are afraid of being touched. And unlike a chiropractic approach that's going to wham bam, thank you ma'am, and make you look straight, or try to get to that really sore spot and beat it up, I really want to talk about the different barriers. So first, there's the physiologic barrier, and that's the limitation of normal motion. Oh, great, and some questions in the chat. So we will get back with those. Thank you. I feel soft and buttery. Love that. That's amazing. So the physiologic barrier is where normal motion goes. So when you bend your wrist this way, this is physiologic motion, right? It's easy to do. There's limited by normal motion, and I'm moving this actively, okay? Now, if we have an anatomical barrier, we test it by somebody else moving it. So I'm not moving it from within, I'm moving it externally. And that's a passive range of motion. And I can get a little bit further. I can pull that a little bit tighter. And that's that second one, the anatomical barrier. Between those barriers is something known as the elastic barrier. And this is what we feel as a difference in motion between these two. And that's where we determine kind of where is the dysfunction. But lastly, we can hit an area that is abnormal in the middle of that physiologic barrier. And I'll be moving through somebody's joint range of motion, and all of a sudden I'll hit a wall and it'll clunk, it'll just stop. And that abnormally diminished physiologic range of motion, we see this in frozen shoulder, we see this in arthritis, we see this in some kind of trauma with a muscle spasm that it hits the end of the muscle. That barrier that's abnormally shortened is going to affect the whole system. And let me show you what this looks like. So here's our end of the line. So our big anatomical barrier, we'll start with our physiologic two, and the end in the middle is neutral. So our physiologic barrier, right, we're going to just move it and see how it goes. And then I can move it further. So between the yellow to the green now is the anatomic barrier. If I would go any further than that, right, I could hurt my wrist. And that's the red lines on the side. The tissue damage would come here on the side from going through that barrier. And that's what we always want to prevent. So by working closer to this physiologic barrier in the active range of motion, we can be sure that we're not pushing that joint past a place that it's safe for it to do that. Because the joints have stretch receptors in the ligaments. And if anybody has ever dislocated a joint or had a sports injury where you sprain an ankle and overstretch that ligament, the only thing worse than too tight of a joint is too loose of a joint. And we work a lot with hypermobile people who have a lot of range of motion, and these end feels are not very clear. And so it's easy, if you're not a very well-trained manual technician or an osteopath, that you can push that person too far. And then their body will react with unsafety. And what happens when an organism gets unsafe? Their heart rate raises, they breathe faster, they tighten their shoulders up like this. Here, I'll show you up, right? We get ready because our body is ready to fight or flight. And if it gets too bad, then we go into freeze, and that's called the polyvagal theory. But osteopathically, when we look at this barriers to motion, normal range of motion should be between this physiologic barrier in active range of motion. When we go to passive range of motion, we end up reaching the anatomic barrier. If you go beyond the anatomic barrier, there's tissue damage. And we don't actually have to go quite all the way to the barrier to do very good work osteopathically. So let's get an injury. So we're going to introduce a barrier restrictively. So we're turning, and I'm going to look at where that goes. And you turn to the right, and you only go 10 degrees when you should go 90. There you go. Thank you, Mithri. That's awesome. So you turn it, and you should go that way. So what do you do when you hit the restrictive barrier? Well, we have some options. It depends on what you feel, okay? So tissue texture changes can either be really acute. These are rubor, dolor, calor, red, hot, swollen. And this is when you go down, that starts to bruise and bleed and swell. And it's an immediate activation. The blood vessels dilate, that's vasodilation, and you get swelling. And what did they tell you to do? Put ice on it, elevate it, rest it, right? This edema comes because the body is sending all of this flow to go heal that joint. It's going to be moist. It's going to start weeping. There's heat and redness. And when you put your hand over it, if you run your hand over the skin, it'll have a rough texture. Or when you push into it, it'll be almost boggy, like it doesn't want to respond. Congested is how it kind of feels. There's also a lot of heat in acute somatic dysfunction. You'll put your hands on, and we see this in the kiddos with head injuries, that like concussions, sports injuries, soccer players get a lot of concussions. It's very interesting, hockey players. But then as that somatic dysfunction sits in the body figures out how it moves around it. It then creates what I see most commonly, and that's usually because everybody doesn't come to me when it's acute, when we can fix it really easily. They sort of wait till it really starts bothering them, or they finally get to the desperate place. And that's okay. I want to make sure you know that's completely okay. That's the human nature. We're going to do that. But what I'm feeling for is the tissue chronicity. If it's a long-standing chronic change, it'll be fibrotic. It'll have these little fibers and textures in it. It'll be itchy. That like when you rub it a little bit, it gets pruritic, is itchy. It'll also be kind of colder than the tissue around it because it's not getting as much blood flow. Think about it. If it's, if you left your bread out on the counter too long, it's going to dry out. It's going to get cool, ropey, stringy, and it's going to dry and the texture is going to change. You got to bake it when it's time. And so this is what we also learned, that how the body processes this trauma, and it'll move from this. And just check in with your body again. What do you think your trauma is today? Do you think you're feeling more of the acute stuff, or do you think you're feeling more of the chronic? Just notice that for a second. And any questions while we're going? Feel free to interrupt me, because we do have some time for questions now or at the end. So, osteopathic physicians and osteopaths use osteopathic manipulative treatment, OMT, to heal somatic dysfunction. There are over 40 different OMT techniques noted in the American College of Osteopathic Medicine Glossary of Osteopathic Terminology. And like this is a type of cranial work. You can see your hands here are underneath the occiput. And when we talk about how I treat, most of what I do is on the right side of this page. That is indirect treatment, where I'm moving away from the restrictive barrier to a position of ease or comfort. And I always start there. That's been my evolution. I trained in a lot of the direct techniques. I can crack and pop with the best of them. But I didn't like to be sore, personally. I didn't like to have the side effects sometimes of when you have to pop it so aggressively that you have the side effects after. And when you allow the relaxation to kind of occur on its own, it's funny because the body starts to do its own kind of dance. And these are techniques like facilitated positional release, counter strain, indirect myofascial release. And then you can think of a direct technique as like pushing it through the barrier. And sometimes when our ribs get dysfunctional up here, like you have one really tight, bony, hard thing and your hand's going to sleep, like a thoracic outlet syndrome, it makes more sense if we can get that tissue freed up to allow it to make a little clunk back into place. So that clunk, that little bubble that comes out, or it's called a cavitation, oftentimes people will get the popcorn, the cracking. That is not necessarily necessary, but it's a nice, satisfying feeling for us as a DO. Like, we like it when it releases because it means that the joint changed enough dimension that a little bubble of CO2 came out. And it's actually safe. It doesn't mean there's going to be more arthritis. Somebody asked me recently, like, if I pop myself, does it mean I'm going to get arthritis in there? It's an indication that there's more motion than the joint is used to. But that joint capsule can expand and contract. Because remember, your body is ancient technology. And it's so, so wise that like sometimes we think we know what it's doing, but all of this is automatic. And these moving through the direct barrier examples include high velocity, low amplitude, HVLA, and even muscle energy is a primary direct technique because you take it straight to that restrictive barrier. There's some combined examples called the still technique. Myofascial release can be both direct and indirect. I primarily teach it indirect. And osteopathic cranial manipulative medicine, or cranial osteopathy, which is my favorite and my specialty. So what does OMT do to the body? This is exciting. So mechanically, it causes a joint or an articular release. It frees up the motion, and it releases the tension of the joint on the vertebrae of the short or long bones with or without that accompanying noise. But you'll actually be releasing the tightness around the bones themselves. And that's one of the reasons it's called osteopathy. Osteo meaning bone, pathy meaning suffering. And what else is made in the bones? The blood. The rule of the artery, Dr. Still said, is supreme. You're all osteopaths now. So when we talk about it, we are caring about how the joint's moving, but we're really excited about the implications after that. And I'm famous for saying that your treatment begins when my hands leave you. And that's because it really does. It gives you this place where your body starts to open up. The lactic acid from those tight muscles is flushed out. The arteries water the withering fields, and you really start to feel better. But that's also the reason that some of my folks, when they get a treatment, they feel a little cruddy for a day or two. Their body's actually detoxing and releasing all of that stored up tension and stored up fluid. So let's talk about the nerves and the muscles. OMT generates what's called an afferent input. And when we talk about neuroscience, there's this cool thing called Hebb's law, that neurons that fire together wire together. And our brain is such an amazing supercomputer that the body is sending all kinds of signals to our brain through the vagus nerve at all times, through the skin. Even how we taste our environment and sample that into our bloodstream is through the lungs. Did you know your lung is about the size of a tennis court if you would spread out the surface area? Insane. It's amazing what's in here, and we have no idea. So that afferent input will diminish the motor neuron discharge in the brain and actually relax the reflex arc that gets tight. It improves blood flow through the vasculature. Nitric oxide, which you hear about, is actually concentrated in the blood, and it'll increase vasodilation when those levels rise. And we have nice studies that show that OMT causes a good raise in nitric oxide and can increase peripheral vascular tissue blood flow. And then let's talk about brain chemicals. We had a lot of discussion over the past few years in osteopathic medicine. Are we influencing the opioid system or the cannabinoid system when we do some of this? And it turns out it's the endogenous opioid system. So that hands-on treatment is actually improving the way that the brain feels pain. And that's really exciting because anandamide is a stimulating cannabinoid receptor in the brain. And we thought that was kind of the initial one, but it's turning out that it actually then goes and it alters gene expression and it changes the way that the opioid flow happens through the brain. We are also seeing that the mechanical disruption of the fascia itself causes the fibroblasts to move, and it may increase the water content of collagenous and cartilaginous structures and glycosaminoglycan synthesis, which is important for collagen building. So there's data that like the treatment that you're getting now may help your body rebuild better later. Now, who can't have OMT? My firm belief is there's no true contraindications if you're seeing a skilled clinician who carefully selects the treatments and apply them correctly. There's some clear ones, like people with Down syndrome have AA instability, and we should never do forceful neck manipulation on them. Anyone who has a history of osteopenia or osteoporosis, I'm always taking that into account. And so a lot of times you'll see me do very gentle, very slow, but kind of firm, just gentle motion. Contraindications will vary by the technique, and like we talked about, osteoporosis, fracture, broken bone, cancer, malignancy, or osteomyelitis, we do not use HVLA for those people. And rarely, I use HVLA maybe 2 or 3 times a week. Other techniques, though, have limitation only based on the patient's ability to follow directions and lie still. And I even treat my toddlers by chasing them around the room, and we can treat their heads while they play or they go through. And Nurse Mary's an expert at toys at this point. So we're really doing amazing work. So let's just take a quick question break. How's everybody doing? Yeah, good question, Mithri. So do I treat acute and chronic somatic dysfunction differently? And the answer is absolutely. A lot of times with the acute stuff, we are working downstream because everything is going to flow towards the heart, right? And the lymphatics also come into this left-sided channel. So I'm going to start very centrally for people with acute stuff and work my way out. For people who are chronic, I tend to start more at the feet and then work my way kind of up to the head because it feels good when we get through. But if your primary dysfunction is up in the head, headaches, TMJ, jaw pain, neck, I'm going to go right there first. I'm going to get that balanced and opened up because the back of the brainstem is going to have so many of those autonomic things where you can rest and get comfortable on the table. Many of my patients haven't ever been comfortable in their bodies, or they've kind of been toxically positive, like I'm looking on the bright side. And we have data that after 3 months of being in pain, your brain doesn't see it in the pain area. It actually sees it in the amygdala, which is like the area of emotional trauma. Like if you get broken up with, your amygdala is just mad at you, the rat brain, right? So I really think it's important to ask that question, and that's why we're so detailed on our history. How new is this injury? How long have you had it? Did you re-injure yourself? Because one thing I see, especially with head injuries and ankle sprains, is it's not the first one that does you in. It's the second one, or then it gets chronically unstable and it's the third and fourth and fifth one, and you're bracing and you're going to PT and you're like, by the time the dysfunction has got going, it does get worse. And we know that the nerves themselves can release these inflammatory neurotransmitters to the other nerves around them. It's called facilitation. So the biggest thing about pain can be so helpful, but the acute and chronic stuff, many people have a mix. Because oftentimes you'll have an acute injury on top of a chronic thing. And that's one of the ways that we determine skill. Skill for an osteopathic physician is knowing what normal feels like and knowing how to help it get there. And each person's a little different, and it's really a very customized approach because of how many factors are going into it. That's a great question. Gosh, what a group today. I really appreciate it. And what is Jay's question? How does this impact surgical scar tissue that is actually preventing the surgical area, the cut-on area, from healing appropriately long after the surgery has occurred? Wow, Jay, what a great question. So when we cut into the skin for anything and we put it back together, it's always going to scar and retract. So you'll notice when people come out of surgery, the tissue, instead of just being pulled together as a line, do you notice how it's always left like this? And you're like, why is it sticking out? Interestingly, that's because the surgeons know this, and they know that when it puts up like this and the skin is put together, it's going to pull down. And that's normal retraction. So a lot of people will have scars from surgery, and surgery is necessary, as we talked about, C-sections, other things, that tissue all the way down in the layers, it's kind of like they get messed up, so they're not messing together the correct way, or they've healed at a different tension pattern. And there's a traditional osteopathic scar release where you pinch the tissue, make a little tent of it, lift it up and take it where it wants to go, and then you have the patient cough. And if you have a scar, go ahead and try this now. This is kind of a fun one. I have one right here. You can also do it on a little skin lesion. So you're going to take it and pinch it, and then you're going to take it side to side and lift it up, and then relax. And then check the tissue texture again. And you want to feel it before and after. And if you have one, I treated one lady this week. She had a four-wheeler accident 3 or 4 years ago, sent over by the hand surgeon, had a 2 or 3 big scars from 4 or 5 surgeries in her wrist that was like not healing. She's holding it tight in her sling, the shoulders elevated, and she's just kind of sitting like this. And it was interesting because I treated through her body, and it pulled me straight into the wrist. And it took me straight into the scar, actually. And we did this and treated, and I had my team feel before and after. I think Nurse Mary's here. She can tell you what it felt like. But oh, got it. Hi, Sharon. Nice to welcome. So good question. So when that scar retracted, it went all the way in. So we had her cough and do the thing. It released through, and her whole neck and shoulder started to open up. Because the one thing is, the body is definitely a non-linear system. One of the things we know is this is kind of quantum, and it has to do with all of the different trauma responses. And scars are a big energy investment for the body. Healing up some of those things takes a lot, as we talked about. So scars can cause restriction, and any of that tension that's causing restricted blood flow is going to be a problem. So again, as we kind of look at some of our take-homes, osteopathy is a system of healthcare. It uses our hands-on approach to treat causes of pain or dysfunction. It's natural medicine, and it's honoring that our body has a capacity for self-healing, that when it's well-tuned like an engine, it'll perform with minimum wear and tear, and it'll restore the body's natural ability to heal itself. We recognize patients as an integrated whole. And that's why your treatment is never going to be the same, for me anyway, every time. And I have no protocols fully that apply to anybody. Even when I'm applying like the parent technique or a different thing, it looks radically different because each time I'm assessing the body both before and after, and then we're documenting the response to treatment. So I'm hoping that one day we can be able to look at the research. How did the somatic dysfunction change? And one of my friends and heroes, Dr. Palat in Michigan State, he's doing this research with babies. And he found that by the 3rd or 4th treatment, that babies actually have, like, they go from having 20 or 30 somatic dysfunctions down to 2 or 3 key ones, because we can help so much with the birth trauma and the side effects of that. So let's talk a little bit about birth and osteopathic cranial manipulative medicine. So these are some of my mentors and the lineage of Dr. Still. Dr. Still's student was Dr. Sutherland here on the right, and he was from Minnesota. he made the famous observation, seeing an expanded skull like down here, that the articular surfaces were beveled like the gills of a fish. He said almost for a respiratory mechanism. He's like, it looks like it's breathing because that's where the fish breathe from. And so he strapped himself in helmets and started lesioning his cranium and figuring out the idea of the reciprocal tension membrane and the craniosacral connection through the dura. And he taught early classes in the 1940s. The woman on the left is my mentor. Her name was Dr. Viola Fryman Dio, a blessed memory. Dr. Fryman lost her first child from intractable colic in the 1940s. She was a former dancer who was treated by a British osteopath. She grew up in the UK. She went to the Royal College of Physicians and Surgeons and became an MD, and then went to a homeopathy school, and then moved to the US and had this experience with her baby, went to osteopathic school, and then learned all of this. And it's been a tremendous gift of my life to get a chance to know and be mentored by Dr. Fryman, because she did some really revolutionary research. In the 1970s, she studied babies' cranial dysfunctions based on their birth patterns. And so she did a retrospective chart review. She would assess the baby's head, and then she went back later and looked at the birth stuff and coordinated the list and looked at, like, what did this birth do? So left occiput posterior or sunny side up, like that was a definite one that caused a lot of cranial strains. And so her mind as a researcher and educator, her legacy goes long in the osteopathic profession. So let's talk about a little labor and delivery. The different bones are outlined on the top: the maxilla, the sphenoid bone, the occiput, squame in the back, and the temporal bones on the side. And the occipital parts have this condylar compression. They can be either unilateral, one-sided, or both sides. And it causes then these vertical strains that will cause vagal nerve symptoms for the babies. And these are the babies that'll be tense or spastic. They'll be sleepless, they'll have a lot of excessive crying. And how it's actually happening is through some of this anatomy. So like this is the jugular foramen. And you can see here on the base of the skull that inside there, look at that like turn. It's almost like anterior posterior, sort of how that jugular vein exits. But also in there is the hypoglossal, vagus, and glossopharyngeal nerve. So if you can imagine here what would happen if that continued to get pinched. And it could have the precursors, they say here, to cerebral palsy. Temporal squamous issues can cause disequilibrium or hearing loss, and we do treat that a lot. Meniere's disease, people who have a lot of dysfunction in this part of the cranium. Hearing loss, tinnitus can often help for this, but it's tied into that petrous portion. If it's a unilateral or sphenoid lesion, those will have lateral strains where the head will kind of feel tipping side to side. And that has those babies have poor suck or vomiting. They have irregular respirations, or they'll be told they have scoliosis and we don't know where it's coming from. It's actually from some of these tension patterns left over from how we hung out inside of mom before we were born. And babies are designed to kind of squeeze, right, and kind of compress and then expand through the birth process. And if they don't get that, the fascia is definitely affected. Also the maxilla, and we see a lot of this with dental, oral myofunctional cases, sleep apnea, and that malalignment of the maxilla can cause malocclusion and dental issues. And then the affecting of the torticollis, side bent TEDs, or you see those babies. How many people have seen babies that wear those little helmets? Yeah, so that's for a treatment called plagiocephaly, where the cranium, the head, is all kinds of funny shapes. And what we found is there's actually a study going on with one of my friends, Kim, at the Osteopathic Center for Children in San Diego, the opt-in trial, where they're measuring with a digital sock the baby's actual head shape before and after osteopathic treatment. And so in the new edition of the breastfeeding literature, there's going to be whole sections of how osteopathic manipulative treatment helps. Because one of the things, as Dr. Fryman's story with losing her child and Sutherland's work has saved countless moms and babies from so much harm of breastfeeding, lactation, and it's already a hard time and stressful on the body. So there's good data that osteopathic manipulative treatment can improve labor outcomes, can shorten delivery times, lessen the need for Pitocin, which puts more squeeze on the baby, and often lead to much better outcomes for both mom and baby. And when we come back to cranial, we're always looking at how two bones move together. These two bones are the sphenoid and the occiput. And that little saddle between them is where the hypothalamus sits. And it's kind of right where that pituitary gland sort of rides in its little saddle. That's also the fundamental place where hormonal dysfunction comes when people get cranial stuff. And when you're feeling a normal head, it should feel kind of like a jellyfish. It should be even. It kind of opens and closes. And I'm putting about 2 to 5 grams of force on anyone's head at a time. So it's a very light touch, and you're almost feeling like the skin of a balloon. And then when we feel what a torsion would feel like one side pulls kind of forward. And when we feel a side bending rotation, it kind of gets, one hand comes up, the other one goes down, and there's a little bit of a twisting, but it feels like a side bending and a rotating. There's a vertical strain which feels kind of stuck forward. There's lateral strains that look like a different parallelogram, and then it can be actually compressed. And this is the scary one that people aren't aware of, is a lot of good craniosacral therapists don't know how to see a compressed CRI, so they put their hands on and it's balanced, but there's no vitality there. It's just really compressed. And unfortunately, I see a lot of patients who come to me after they've seen other clinicians. And I'm excited about revealing my trauma-informed touch course and some cranial updates coming soon, so I can teach people how to disrupt these patterns without causing the harm, because it can be really nuanced. And that's something that Dr. Upledger, who founded craniosacral therapy, was a Michigan State trained DO mentored by Dr. Freiben. And he kind of began his own enterprise, and it's been beautiful to see. He also got into some emotional releases with that, which definitely happened. But traditional osteopathy has researched and innovated more into understanding how these bones move and what the consequences are. And that's kind of where we're excited to go with the glymphatic system and how the brain clears toxins. So when the head treats, this is kind of the coolest thing, and this happens with all over the body. So initially you'll feel the pattern of motion, and you'll see that craniorhythmic impulse, number 1 and number 7. And then we take it into that passive, spontaneous range of motion. And it'll exaggerate it, and the anatomy will kind of retrace its steps over the path of least resistance. And we'll engage a little bit that restrictive barrier, see where it goes, and we use really graduated force. But at that point, we'll notice number 3, a central kind of subtle unwinding. And this gross motion pattern is sensed during a kind of a swift indirect technique. And then it'll go to a balance point, and you'll feel it, and it'll kind of stop, and you're supposed to hold it and kind of wait for further instructions, but it's kind of gathering energy. It's trying to figure out how it's going to change that whole area. And then as the release ensues, all of a sudden it'll switch, and you'll feel it kind of start to jolt or twitch or jerk or melt under your hands. Oftentimes you'll feel a therapeutic pulse, and it'll just start to tip, tap, tap under your finger. And then everything gets really quiet. And one of my favorite ending points of a treatment is the still point. It's when there's noticeably less force or tension required. You're just sitting there, and it just feels like a tiny bird sitting on a wire or a little boat on a quiet ocean. And it's when the whole part is integrating in the whole. A real osteopath can put his hand on a part and feel the whole, or put her hand on the whole and feel a part. And this is fun with the mechanism of how we do that. The other places that are really interesting to treat are the eyes and ears, and this is actually an orbital contact, and so you can treat the eye itself within the socket. And this is Dr. Freiman's hold. And as we kind of get a chance to finish up here, and I'll stay as long as we need to for questions, that osteopathic manipulative treatment is defined by these 4 tenets, that it's a set of techniques used to treat these somatic dysfunctions, and DOs are trained in osteopathic principles and osteopathic treatment. MDs can do this safely, and again, feel free to ask your clinicians, hey, who did you train with? What are you learning? How do you integrate this together? Because I also think it's beautiful, and one of the reasons I love practicing in Michigan is I have amazing colleagues. I've worked at a couple of different practices in the area, and people have many great options for care. One of the cool things we do is a complimentary discovery call for anybody who's interested. And I just ask you to fill out your health history, and I'll spend 15 minutes and go through stuff with you and see if we can help you. And we also have an option too for a virtual posture consult. If anybody's like, hey, I got tight shoulders and need this, send us a message. We can help you out. And OMT is the modality that can safely and improve functionality for back pain, neck pain, joint pain, headaches, and improve athletic function. We also notice a lot of improvements for performing artists who can't safely take a ton of medicines, including dancers and actors and singers and instrumentalists, and folks who really ask their body to perform a lot. I think the space that is really exciting for me is osteopathy and longevity and human performance. Like, how do we live lives? Because I looked at these osteopathic physicians, and they age well, compared to some people that look a lot older than they are. It always seemed like our mentors were by us. So here's my picture in the theme of my mentors with my hand on the skull, looking all osteopathic. And I really am grateful for you all today spending the time. And I'm going to get through some of these other questions in the chat. And then if there's anything more, feel free, we can unmute. Okay, so we asked, what is a considered part of total health? Very good question. And what are some common methods for treating each portion? Pia, clarify if I don't get it covered all the way. So osteopathy kind of as the whole, the total health piece, is about how the organism exists in its environment. And actually, maybe I should show you all this PowerPoint for a second here. Let me share this other screen. Okay. We'll stop that one for a second. Here we go. Good deal. Okay. So one of the things we ended up treating a lot is chronic fatigue syndrome and fibromyalgia. And this is a really interesting, continue to share that PowerPoint window. Okay, can you see that little video? Excellent. All right, we're going to see if it will let us take it and make it go. Come again. Perfect. Okay, so this is a video of lymphatics. And I want to show you a normal flow first. So this is the thoracic duct, and here's an ultrasound image. It's right up here by the neck, and it's going in, and you see how it's kind of squirting pretty evenly and filling, right? Now look at this next patient. This is from the New England Journal. This is a person with lymphatic dysfunction, and that thoracic duct is sluggish and dilated, and it's not squirting the lymph back into the system, which 80% of the lymph in the whole left side of the body has to drain down through here. So this lymphatic system, actually, this is the picture of it, that thoracic duct that comes through. And we're seeing now that this can back up and cause megalymphatics, including down into disrupting the GI system. And that thoracic duct turns up here and it arches forward and descends in the left venous angle into the subclavian. And as that comes through, you can see the little red there. So this thoracic duct, here's what it looks like when you're taken out. And this is one of the main lymph channels that is carrying all the lymph back in. And the lymph itself is the trash. It's the leftover products that have come through, and the body itself is trying to give that feedback. So where this drainage comes through, we often talk about lymph nodes, you'll hear, and there's about 700 of them in the body. 300 are from the nose, kind of through the nipples, right through the central part, because everything has to drain back to feed in. And when we see these lymph nodes, that moving fluid into the lymph vessel is not passive drainage. So when this gets disrupted, it's really dangerous for the organism. We have new data talking too about the 4 places that CSF, cerebrospinal fluid, drains out of the brain. And I want to cover this briefly because it's important for Alzheimer's and chronic fatigue syndrome and fibromyalgia, that the cribriform plate right here in the front of the nose is about where 50% of that cerebrospinal fluid drains. It also drains down the cranial nerves and around these meningeal lymphatics in the back and down the spinal nerves. So there was a whole different pathway on this lymphatic system. And it was discovered in 2016. But this Dr. Rasmussen, and here's the inside of the skull in the cribriform plate. And you can imagine these nerves going down, the nerves, the arteries, the venous return. But around each one of those blood vessels is actually lymphatics. They encircle that and go down around the area, and you can see that here. And that's what's actually causing. So here's the blood vessel. That's what causes the blood-brain barrier to be built. And there's actually another thing, and we're seeing it through the CSF tracer now. This is Dr. Iliff's work, that cerebral spinal fluid actually goes down around all of the arteries. So this is big deal because we thought CSF just kind of stayed and recirculated. But another famous still quote is the highest known element is the cerebral spinal fluid. And so in this area between the dura and the arachnoid, we found a whole new membrane called the SLIM. And that's a subarachnoid lymphoid-like membrane. And this was, again, Nature 2015 and the SLIM. It's an area that keeps the small molecules from the large molecules. And then when you see this from the University of Copenhagen, I'll share this PowerPoint later. I'm going to put it online. But it's an extra layer that lines the brain, and that the brain is surrounded by 3 layers traditionally, but this immunophenotypically distinct 4th layer is what allows the large solutes, like the insulin and other things, to cross into that blood-brain barrier. And it disintegrates very quickly after the body passes. So we were never able to understand what the immune system of the brain was. Like, why did some people get meningitis and some people don't? This layers. And it can be disrupted with any kind of head injury. It can be disrupted with infection. If you get a sinusitis, you know how they say it can go back into your brain? That's true. Eye infections as well. And this is something, 2023 data. So it's extremely thin, and it's so close that we've missed it before. But here's the last thing I really want to share is how exciting this CSF drainage understanding, that the subarachnoid space here, this is our traditional understanding, and the yellow is the CSF. And notice the disconnection here. Well, one of my heroes, Dr. Pessa, he's a plastic surgeon who was doing a really interesting surgery, and he said, I saw these little vessels in the neck. He was doing a chin lift or something. He saw these little tubes, and he said, I got to figure out what those are. So he called his friend, and they went in and found in the top of the skull, cutting in here, this is within the superior sagittal sinus, and you'll see this little tube. And look at that on the left side. See that little clear tube in there? That is known as a CSF canaliculi, and it's here on the side of the superior sagittal sinus. Dr. Pessa found the CSF canalicular system as a separate flowing system, draining the brain and allowing for extra drainage. And when the cervical spine is tight, it impairs this drainage. And so let's see what it looks like. So again, this is going all the way down into the neck is where he's dissecting here for you to see. And as you come back in, you'll see the canalicular system in here drawn in, these perforating lymphatic vessels, and a whole tight side of the CSF system that takes it directly down to the subclavian vein. And we've now been able to see this with tracers. So this is our vagus nerve. Here was our traditional understanding of the lymphatics. And here's our current understanding with all of this. And you'll see my hands a lot of times on these areas of the brain, improving that lymphatic stuff. So we then proved it in primates. And here's the MRI showing it. This is neuroscience. And then this is one of my favorite pictures of all time. It's a 3D rendering of these lymphatics in a 47-year-old woman. And you can see the structure and the shape and how it factors into this area right here, this insula and singular cortex. That's where all the emotions are. That's where that amygdala is that we talked about. That's deep down to the brainstem. So it's really important that we start to understand osteopathy in a more neuroscience-based perspective, in my opinion. Lastly, why are we going to end up and go to sleep tonight? Well, because when you don't get sleep, your brain doesn't clear itself. And we have this proven in mouse models now that when you get REM sleep, that it coordinates and it syncs with the brain. And so sleep disruption is going to be seen as a reason for Parkinson's, Alzheimer's, chronic fatigue syndrome, long COVID. And it's all driven by norepinephrine. And one of the medicines that is most used and is one of the most unsafe for this is Ambien or Zolpidem, because it'll stop those oscillations and change that lymphatic flow. So here's what that cross-section looks like. And a lot of this research comes from another one of my heroes, Dr. Perrin. And many of you have heard me speak about Dr. Raymond Perrin. He's a DO osteopath from the UK. And he was studying chronic fatigue and fibromyalgia since 1989. And the last article I wanted to show you about the lymphatics is what came out actually in April of this year from Korea. And they found out that by improving, um, by manipulating the cervical spine, that they proved increased drainage of the cerebral spinal fluid through these lymphatics. And here was a monkey model that they traced through, and they saw here the areas that came around the face that drain around here in the facial lymphatics. And that very seems to match with people who have some of this temper. So Dr. Perrin said there was 4 stages: a trauma, then congenital difficulty that had physical damage affecting these perivascular spaces in the area of the brain. And that's where long COVID came from, because it affected that cribriform plate. There's a buildup of stress. He said there's always emotional stress, physical and immunological, which is either infections or allergies, usually complicated by environmental trauma or other pathologies, and that this external stimuli all affects via the limbic system, the hypothalamus. And that's, again, that hypothalamic area is so important to osteopathy that, of course, it would affect the hormonal system, and it would affect the way that the body can respond. So he said for chronic fatigue syndrome, and this is true for fibromyalgia as well, that sympathetic overload, that we were too uptight for too long, caused it to break down, have retrograde lymph flow, and build up toxicity in the brain. And that the symptoms, the tiredness, the fatigue, all of the things are coming from this hypothalamic dysfunction. Dr. Perrin published in the British Medical Journal, he found 5 signs of chronic fatigue syndrome and ME that we learned to diagnose. And we're really privileged because Dr. Perrin is coming to Michigan for a training for CME in March. And so if you're interested in more of this, this is some of the physical signings we see: varicose megalymphatics. And I taught this lecture at Beaumont a few weeks ago, going through some of the different physical signs. We've actually seen too that ME/CFS causes a dorsal root ganglionitis, and this is an autopsy photo from that nice lady we saw before. So he also saw that there were all these spinal injuries. And so if you see anybody in your life or your practice, or maybe yourself, that has a sunken thoracic spine, usually it should be curved nice like this. If it's sunken in, or you have weird scoliosis and a lot of pain, it might be helpful to get checked out for that. So Dr. Perrin found out some really cool things, but he's published a couple books, including Through the Looking Glass, which is his new book on the SARS coronavirus 2 and triggers, and we're seeing that in 70% of long COVID. So he'll be visiting Michigan in March, and the Perrin technique is a beautiful option that we can see improve some of this lymphatic drainage. So I'm really excited again, and love from our candy stripers. This is Pip and Kate. So I am really excited to do some questions and spend a little time with anybody who has any more questions, and I'll finish through the chat here. So good question. Let's talk about ADHD. Osteopathy treating anxiety and ADHD works through about 3 separate mechanisms that we understand. The first one was the reward dopamine system. Because if those neurotransmitter chemicals aren't able to be freed, many ADHD folks have had severe head injuries or infections that have worsened, and then the sleep will also worsen the ADHD symptoms. So one of the things is we're taking down all of the extra load on the body so that it can kind of calm down. Another thing is a lot of people see ADHD as a problem, sort of. But it may be more of an evolutionary adaptation to our screens and our tech. So anybody who I work with ADHD, we do magnesium and theanine, and we look at MTHFR or methylfolate and see if they have COMT deficiency, because a lot of people have methylation problems. And one of my patients, she came to me, a therapist who was having a lot of autism, ADHD stuff, and tried all the medicines, had gone to a point where she had 2 or 3 different psych medications, a sleeper, an ADHD medicine, and she had high blood pressure from the medicine. She was not feeling well. She couldn't lose weight. And we did a genetic test for the 5 sites for her methylation. And she had a COMT deficiency and the MTHFR, which will impair 2 types of dopamine signaling. And we got her started on the methionine and some of the methylfolate. And she came back the next time and she looked at me and she said, "Is it weird that I feel less autistic?" And I said, "Well, no, because we're giving your brain what it needs to make the neurotransmitters that you have to have, the serotonin and the norepinephrine." Also, that the idea that depression and ADHD and anxiety comes from a single imbalance in like serotonin and norepinephrine, we have actually disproven. And they're talking more about the mitochondrial effects. And that's also to do with the chronic tension, because the tension that you get in your muscles too, a lot of ADHD people have a ton of jaw tension, and they'll have a lot of these things leading to the diminished brain flow. And so you're like, oh, is it a lymphatic congestion problem? Is it like predisposed genetics? But the cool research for me on osteopathy is when we're talking about gene expression, right? So what tells the gene when to turn on or when to turn off? That's what we don't know yet. That's the epigenetic factors that even in people with the BRCA gene, the breast cancer gene, that 50% of folks who have this will get that. So they put them on medicine and cut their breasts off. My question is how do we figure out which 50% keep that from turning on or turning off? Because I think people have the capacity for schizophrenia or ADHD, right? And when your body's put under so much chronic trauma, that there's nobody that has ADHD or anxiety that hasn't had something happen to them. And so also I think it's important, and one of the things that I do is I really try to validate where people are, because nobody comes in feeling great. And oftentimes focus can be misdiagnosed, but I see it also with just chronic tension, that some people get the tension gone and they learn how to sleep and they're like more able to focus. Evolutionarily too, I think we were more designed to focus for like 20 or 30 minutes and then have a break, right? Like being outside and hunter-gatherers. And I just think it's really interesting. And that's such a good question. And I think it would be an amazing research study. We could double blind and see, like, how did people go? And now with the gene testing, we should be able to see how it affects things like neurofilament light chains, which are direct markers of brain damage, so that we can maybe actually measure the response to treatment. But ADHD, they all have a cranial strain pattern typically, and they often have a sacral strain where the sacrum will actually be holding some of the cranial stuff. And that's very fascinating. Did I answer your question? Yeah, okay, perfect. Um, oh, and anxiety is a little bit different, but kind of similar. It's more about how the organism feels safe in its environment, right? And if an organism's under pain and feeling bad all the time, it's not going to thrive. Like it's going to retreat because it's not going to feel. So there's a lot of data that osteopathy maybe doesn't, fix the dysfunction, but it allows the organism to handle the stress of it much better. And I think that's a really cool, it's an N ecological model. So I think that's really interesting. Another question, normally migraines are said they don't have a cure. Can osteopathy treatment exist or to limit or remove? And does CSF have to be with it? What a great question. Thank you for this. So migraine is a huge epidemic in the US, and we see a ton of drugs. And their effectiveness is very inconsistent for people. Some people really respond well when they take the triptans. Some people are using, Lady Gaga was up talking about Emgality and all of these new drugs. And so when we talk about migraines, there's three things that happen. There's a vascular component of tension and blood flow issues that does block up the CSF, really good for them, that's perfect. It does block the CSF and it causes inflammation. We also see the inflammation of the acute dysfunction, right? When that blood flow gets in and it can't get out, there's increased pressure. And that's that throbbing that happens for people. And then we'll typically try to treat it with medicines that'll turn down the blood flow, right? That'll stop the pounding. And that's the caffeine or Fiorset that they give people. But that actually has a rebound effect because when you tighten up these blood vessels, the pain goes away immediately, but it doesn't necessarily stop the cycle of pain that's happening because migraines are chronic. And the reason they are is because there's areas of the brain we think that are sensitized to that. And I do get a lot of headache or referrals from headache neurologists because osteopathic treatment can treat all of the stuff that the meds and the Botox can't treat, which is the deeper fascia. And nobody's been factoring in both the lymphatics and the pressure. And one thing, I'll teach you a quick exercise, everyone who's been staying. If you want to grab your nose at the base here and kind of push upwards or pull down, do it where it feels good. And you'll start to get a little bit of a kind of a relaxing sensation. And we can actually directly influence our own brains. And it's funny, you know, when you kind of can't focus during a test or something, you kind of pinch your nose and you'll sort of move it around. And the first thing a baby does, right, they hurt themselves, they put their hand on it. So touch is one of these ancient things for our bodies. So as you feel that, and then you can just kind of pull it down and then go ahead and spread on your upper head here. We'll do a quick little migraine one and go ahead and pull this open. You're just pulling along the side and I'm kind of letting my fingers get right in there. Yeah, kind of like you're spreading your crown open. That feels good. And you can be a little firm. Like, go ahead and try it out. Try twice as much pressure, then try half. And I'm gently pulling here. Yeah. And then pull it back down. The other place you'll get a lot is sort of behind the ear on the mastoid process. That's where that jugular foramen goes that I was showing you before. So that jugular foramen that turns there can be a lot of inflammation in that canal. And when the blood vessel itself gets inflamed as it's going through there, it swells. And what happens when something swells into bone? There's nowhere for it to go. And so that's part of the reason we're getting that big throbbing. And what we find is if we can release the shoulders and the neck and then the deeper ribs up here, then it improves that drainage. And it's kind of a siphon effect. So then you start to get this fluid moving out of the brain and it pulls more with it. And if you can use osteopathy with migraines, we have good data that we can reduce the frequency of migraine with osteopathic treatment, and it definitely is helpful. And what's cool is you can take some of these techniques and apply them. I love to teach applied osteopathy where you start to use your hands to feel what's happening and learn how your body works. Because the more we do, the more that we can discover. And I would agree with you that osteopathy treatment can limit and improve migraine symptomatology dramatically. Most headaches that I see, I can improve by a minimum of 50% on the first visit. And then we have a few other tools we pull out. I have a really nice lady who has intermittent hemicrania, like she has ocular migraine, so it feels like a hot poker in her eye. She had tried the medicine and been on 2 or 3 different ones, and she had a 3-week migraine that wasn't breaking. And we used some ear acupuncture with it to actually shut down the full pain cycle and let her body reset along with osteopathy. And she went home and texted us that she slept for the first time in like fully for 2 weeks. And then when you can restore the sleep, that's the last thing that happens with migraine is not only the pain itself, but the fear of the pain. Because you get to this point where you're like, oh my God, am I going to get another migraine? Am I going to get another migraine? And then your shoulders tighten and then your jaw tightens and you're like, oh shit, I have another migraine. It's so rough. I'm so sorry to hear that somebody's dealing with that because it's one of the hard ones and it's one that there's so many options for that if people are willing to come and check it out, I would really love to show you how we can help. I do have a couple videos on social media of me doing a treatment for an acute head injury on our friend Courtney. There's a 2-part video that might be fun for you to watch for the headache because it's very similar treating an acute head injury to a migraine headache because it's red, hot, boggy, exactly all the things you learned about acute somatic dysfunction. I love these questions. OMT is combination with Nurtec has helped immensely with my migraine. Yeah, thank you, Annie. And I think Annie sees Dr. Goldman, who's a lovely osteopath in the area. She's one of my teachers and colleagues. And honestly, that's what's really nice about working with an osteopathic physician like our practice. And it's beautiful to be able to prescribe because I can refill medicine like that. We can try different things. And one of the things I learned about being a doctor is it's really a privilege to get to work with people. And I don't tie it to the outcomes. Like if I need to use hypnosis, I need to use I mean, ethical placebo prescribing I do for some people with IBS. I'm like, this is a sugar pill. It's not going to help you. And it helps them. But like, that's the data of them believing in the safety of figuring out what your body is and a little bit of targeted supplementation. And magnesium is the other thing for migraines that I would recommend almost universally is that magnesium will improve both the muscle tension and the headache frequency. And often in the emergency department, we use IV magnesium as an acute headache treatment. And we often need to just calm down and get that quieted. How would vestibular migraine be different from migraine? Really good question, Amy. So a vestibular migraine, similar to that temporal bone thing, is going to have a lot of the ENT components. There'll be dizziness, there'll be pressure sensation into the ear, and we know that this system I talked about of the lymphatics is actually contiguous into the ear. The endolymph of the ear is a part of that same system. The fluid's a little different. But I do think that inflammation can get in there. And then when one nerve's irritated and it's up against another nerve, as you saw that area, those irritations, those little inflammatory mediators, tumor necrosis factor alpha, interleukin 6, they will increase and bring more inflammatory mediators. And eventually those are going to pass to the next nerve. So the reason that migraine is such a hard thing and for most people is they never get the inflammation stopped. They've never actually gotten it quieted down, and that's why we end up having to use steroids and Botox and some of the heavy hitters to try to do that. But like with any medicine, the steroids aren't safe to use forever. So then we get into this cycle and kind of dance. And like we talked about, people get really worried about it. And that increases the stress response. So typically the biggest success is when we can combine the mind-body techniques together, as well as work on the fascia and remove the inflammation. I hope that answered your question. If there's anything more, feel free to put it in the chat or chime in. I'm coming in so you can hit my head with a hammer to fix my migraines. Yes, I love you. I will be your bone wizard. Um, no, that's really, really, really awesome. Um, I'm just super grateful for this lovely container, and thank you all for staying a little bit more than even I go. I've got a little bit more time too. If there's any other questions that didn't get covered, would love to hear them. But if not, I just am really excited. We have a couple more things to share coming up. Dr. Perrin is coming to Michigan for a training with us in March 6th through 8th. We're going to be having a basic cranial boot camp before that. And I'm working on revealing our trauma-informed touch course. And this will be for different doctors and people who can touch. And we're going to talk about how this nervous system and touch work together. Remember, any of you are interested in a complimentary 15-minute discovery call, but we're going to put a code on. And I believe it's going to be Masterclass. It'll be live tomorrow, and it'll be coming back through for 30% off your next visit as a thank you for coming through. So we're really looking forward to seeing more folks by the still waters. And thanks again for this beautiful, beautiful time. Thank you, everyone. Look forward to seeing you by the still waters. Have a wonderful evening.